Inspired to Heal, Season 2, Public Health Stories. In this season, we recount important public health advances, whether through outbreak investigations, policies, or program building. In each story, government agencies played critical roles. I'm Bill Trick, your host for Inspired to Heal. On today's episode, I welcome Dr. Denise Cardo and Dr. David Henderson. Denise is the former director of the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention, and David is the former deputy director for clinical care and hospital epidemiologist at NIH's Clinical Center. David, Denise, it's great to have you on the show.
Thank you very much for inviting us on.
Very happy to be here.
So I want to start with David. For people who really don't understand what a hospital epidemiologist is or does, could you describe what your role is and maybe even a typical day if there is such a thing?
So first off, let me start by saying that if you wanted to find a typical hospital epidemiologist or in a typical hospital, it wouldn't be my hospital. A hospital epidemiologist is really charged with preventing the transmission of infections in and around the hospital and in healthcare in general. They develop policies and procedures to try to make the environment as safe as possible. Hospitals will never be risk-free, but we've learned a lot of things over the last few decades that one can do to minimize risk in the environment, and that's really what the hospital epidemiologist is charged with. I often divide the job into 4 parts. One is surveillance for healthcare-associated infections. Secondly is investigation of outbreaks. Third is education of staff. And fourth is contributing to science.
David, you entered this field at the very beginning.
Yes, I did.
Why? What drew you to be a hospital epidemiologist?
I had finished my fellowship in infectious diseases. I was working in the laboratory with a guy named Jack Edwards, who was working on Candida albicans at UCLA. I was really pretty interested in clinical mycology. Jack Bennett was the head of clinical mycology at the clinical center. I had 3 job offers, and I called him up and said, Dr. Bennett, can you help me process through these job offers? He said, I'm happy to help you do that, but let me give you a 4th option. You could come back to the NIH Clinical Center and be our hospital epidemiologist. We've never had one, but we think we need one. And I have a position for that. So naive as I was, I went back and interviewed. I got creamed in the interview. On the list of people who I interviewed with was Anthony Fauci. That should tell you everything. I just got bludgeoned. I was supposed to give a talk at 4:30 in the afternoon for 45 minutes. And I didn't get to the room to give the talk until 7 o'clock, and everyone was still in the room waiting on me. I was finally relieved because I was going to be able to do this, and I put up the first slide, and people started saying, what's on the x-axis of that graph? Did you have a control for this experiment? I sweat all the way through my suit, and I couldn't even spell epidemiology. And so at the end of the evening, we went to dinner, and I was sitting next to Dr. Bennett's wife, and she asked me if I had started looking for houses. She said, they love you. They want you to come. I said, someone should tell me that. So I was stunned. I came back to the clinical center, and I learned on the job. Mm-hmm. And I was fortunate enough to make friends with people at CDC who helped me. I couldn't have done it without them. And then we got HIV infection. It made hospital epidemiology a full-time job for a lot of people, and it certainly did for me. I view healthcare epidemiology as my primary affiliation now, not infectious diseases or internal medicine.
So you became the first hospital epidemiologist at NIH's Clinical Center. Can you tell us a little bit about the hospital at the NIH?
It's the only hospital in the United States that's totally dedicated to clinical research. Every patient who comes to the clinical center comes to participate in a study of one kind or another. The clinical center really specializes in rare diseases. Sometimes there may be only 12 or 15 of the patients in the world, but at the clinical center, we had the world's expert in the gene product, protein, or whatever was abnormal in these patients. And they wanted to study those patients because they could learn more about human physiology. And in the course of doing that, learn how to take care of these patients better and more safely. The other half of our studies are really what I would call natural history or disease pathogenesis studies. And those are usually the patients who have rare and genetically determined diseases. The clinical trial portfolio at the clinical center doesn't look like the clinical trial portfolio at most other academic centers. Most academic centers have ongoing clinical research, but most of their studies are phase 3 and phase 4 trials. At the clinical center, the last time I looked, I think 93% of our studies were phase 1 or phase 2. Because we have all these new drugs, all of these new things that are going on, and there's a different level of risk associated with those kinds of studies.
Could you define a phase 1 or phase 2 for people who are not familiar with those terms?
Yeah, phase 1 studies are first in human studies. So it's the first time the drug or device or whatever has ever been put into people. And during phase 2 studies, they often do dose finding to find the best dose or the highest dose you can give without toxicity. Phase 3 trials are efficacy trials generally to show that the drug or device or whatever you're studying actually works to do what you think it does. And then phase 4 studies are post-marketing studies. So once a drug has been marketed or a device has been marketed, people study it to look for rare events or rare complications.
The NIH Clinical Center really is the lifeline for patients around the country and perhaps around the world who have a rare condition. It's hard to do a study when you have one person, spread across a region and you're able to bring them together. The proximity of laboratory research, the best scientists in the world working with clinicians to solve problems.
Yeah, it is a simultaneously wonderful and terrifying place to work. Yeah. The great thing about working at the clinical center is you get to work with an enormous number of smart people. And I mean really smart people. That's the good news. The bad news is you get to work with an enormous number of smart people. And that can be harder than you can imagine because they all think they know how to do your job. In addition to being the world's expert about something, they'd be happy to tell you how you should be doing your job. But it is a treasure. The clinical center is a national treasure that almost nobody knows about.
Mm-hmm. It brings up a couple of questions when you have clinical trials and protocols that you have to adhere to, and you have guidelines for infection control. Did they ever come in conflict with each other?
Oh, absolutely. We work with our investigators to try to make it as safe as we could. Let's imagine that you're using some live virus vector for some kind of gene experiment, and they've never used this vector in humans before. You don't know whether it gets spread, whether it actually multiplies in a person. So all those things have to be thought through up front. And the review process to get such a study done might take 8 or 9 months.
Mm-hmm. Being in the unique position at the clinical center over your 30 plus years of working there that you could point to that, maybe this advance would not have happened, not just clinically, but maybe in hospital epidemiology.
Very early in the HIV epidemic, our colleagues who work downtown in DC called up the director of NIH and said, "What is this new disease and what are you doing about it?" We very quickly had literally hundreds of AIDS patients admitted to the clinical center at a time when no one really knew what caused it. We were pretty confident about the epidemiology, but not entirely. And the healthcare workforce in the clinical center was terrified. And so we began studying occupational risk in that setting. We actually learned a lot about factors that contribute to risk for occupational exposure and occupational infection. And so that's how I got to know Denise, because I got to be a consultant to CDC on this very issue. I don't know how many times, Denise, 20, 30? That's a big number, but
many times.
A lot. And the other thing that happened is we had a very unfortunate event early on in the epidemic. We had a healthcare worker who got infected. There's a woman working in our transfusion medicine department who did something I had done thousands of times in the laboratory. She was spinning down serum in a red top tube. She took the pipette after it had spun and pipetted off the serum. And she had the stopper in her fifth finger and she cranked the stopper back into the tube. The sidewall came out of the tube and she cut her hand. 16 days later, she was febrile and developed the acute retroviral syndrome. And about 2.5 years later, she died. This was before any retroviral treatment or post-exposure prophylaxis was available. Because of that, Sam Broder and his colleagues in the Cancer Institute were studying a drug called BW509U, I think, which turned out to be zidovudine.
Mm-hmm.
And there was early evidence in the clinical center, and this is a great example of what you could do in the clinical center that you might have a hard time doing elsewhere, especially studies done by Phil Pizzo when he was in the pediatric branch of the Cancer Institute. He had infusion studies of children born with AIDS who would literally wake up with the infusion of zidovudine. It was astounding to see it. And so with this in mind, I went to the medical board of the clinical center and said, listen, we have this drug, which we know has activity. If we have healthcare workers who have occupational exposures, don't you think we could offer them, not require them because it was an experimental drug, but if they wanted to take it, they could take it, and then we could study that. And so we started doing that. It did make some of my friends in Atlanta unhappy at the time.
It wasn't me, Bill.
I know it wasn't. But it was.
Yeah.
Simultaneously on the West Coast, my good friend and colleague Julie Gerberding had access to the drug and was doing the same thing. Probably Julie and I were the driving forces behind offering post-exposure prophylaxis in the country.
Yeah.
Denise did the benchmark study. The data were so compelling that in her New England Journal of Medicine paper that said that healthcare workers who took zidovudine had their risk reduced by 79 or 80%.
And Bill, they were really critical for everything. Like the study I did was just put 2 and 2 together for the things that they were doing. But because the trial that they were trying to do, it didn't work. Nobody wanted to be in the control group.
Right.
That's right.
So they couldn't do it.
Yep.
So, but everything we did when I came to CDC, everything we did was based on what David and Julie were doing and really complementing each other. But if it was not what they were doing, we probably would not even having now pre-exposure prophylaxis for non-occupational, post-exposure, like for perinatal transmission. So it was a lot of really innovative and not easy because many groups were against.
Oh, yes. No, I mean, we took a lot of heat, but we persevered. Once UCSF and the NIH Clinical Center started doing it, a lot of people started doing it all around the world.
It's good that you persevered. Denise, you could suspend some humility and just kind of talk about that study, which was really important and probably saved countless lives. Denise, you did this important study.
It was to look at risk factors. The risk is higher if you have a deep wound. So it was more to look at this. And it was a big surprise when we saw not that we didn't expect, I didn't expect the study to show that result for post-exposure prophylaxis. And so we did all kinds of analysis. We tried to see, okay, something is not right. But it continued. The interesting thing to me, Bill, when we published the study, people were criticizing. First, they were saying, you were recommending AZT, now they are new drugs. I'm like, I'm not recommending anything. We're just doing with the drugs people were using. It's just a concept. And going to some of the HIV meetings, I remember telling people, I'm going to wear impermeable suits because the experts would say, it doesn't make any sense. And you guys in healthcare epidemiology don't know what you're doing. So I'm like, I'm so sorry. That's the results. For me, what was interesting, the study was interesting, but how to make from one finding plus a lot of background information to make a policy for the country and how to adapt that to different realities. That for me was a very interesting and amazing experience because then we had to recommend, we had to say as soon as possible. We didn't know exactly the interval. And we put EG 2 to 3 hours. It was clear to me how much we had to be careful with the words, because although it was a guideline, it became really an enforcement document. But also then, okay, what do you do with the dentists? We had to work with partners to adapt. What we wanted is that people would get the drugs as soon as possible. After that, we start looking at cases that didn't work. Let's analyze the failures of post-exposure prophylaxis. I always say people think that the paper is the end. The paper was the beginning of many, many things that we end up doing. And then until now, we see a lot of impact. And then it started like, okay, but let's prevent the injury. So near stick prevention. So it really helped me when I became a division director to have the perspective and how you really go from finding, a very important finding, to guidelines and implementation for huge impact.
Love Denise's study because I love things in medicine that make sense. And Denise's studies, except for the finding of the drug, made perfect sense. So it showed that if you stuck yourself with a hollow bore needle, you were more likely to get infected than if you stuck yourself with a surgical needle. If you had a deep injury, more likely to be infected compared with a superficial injury. And I guess the third one I remember is if the person was late in illness and died within a certain amount of time of death. And so all those things are inoculant effect. That just makes implicit sense. And if you think about it, all those experts who hollered at us, that makes sense because we don't typically prevent viral infections with drugs. We prevent them with vaccines. So this was non-traditional, to say the least.
In the microwave safety episode that I just also recorded, they published the risk and decided that they wanted to take a public health approach. And by the public health approach, you have your finding, you publish it, and then you need somebody or some entity or organization to follow that through, which is the long, hard pathway to get this into be a policy or to influence a regulatory agency, and the value of having public health there to do that. The paper is the beginning of your work.
Yep.
Could you also, I think now it's much safer for patients and for healthcare workers, and post-exposure prophylaxis is one thing, but I think there are engineering innovations as well.
Denise talked about the difference between primary prevention and secondary prevention. Primary prevention is preventing the injury. And if you can prevent the exposure, no one's going to get infected. And so we created a protocol through which, with every single occupational exposure that got reported, we would sit down with them, interview them, look at the circumstances of injury, see if there was a piece of equipment that might be flawed or that might have contributed to it. And we would then process through and change our procedures if we needed to try to make the environment safer. And I have this great slide that just shows occupational exposures reported to the Occupational Medicine Service dropping over time, over years, as we just continue to do that as an iterative process to try to make those exposures go away. We still have some recapping that goes on in the clinical center. There are some places where they have to do it, but we developed a workaround. We developed an engineering control so you don't get your hand down near the needle to recap it. And we've not had, at least by the time I left, we'd not had any exposures associated with that device.
Bill, the role for CDC is highlighting the issue, is promoting education, is promoting more ways to prevent, not just exposures, infections. CDC does not develop products or test products, but CDC will have some analysis of risk factors, of circumstances, of things that can allow industry to address. So this is not just for needle sticks. This is for everything in our field, in healthcare epidemiology. It's a lot of partnerships that not just with industry, but with academic centers that move towards that. But CDC does not develop a specific device. We cannot endorse a specific device unless it's like 100% and it's the only one. And that's the reason it was having HICPAC, the Healthcare Infection Control Practice Advisory Committee, was very important because they will look at all the data and decide which device, which approaches that we do have data to show that we should recommend. Mm-hmm. And that's the reason HICPAC was created.
Yeah, HICPAC would be analogous to the ACIP or the Advisory Committee for Immunization Policies.
Yes.
And, one that's very topical and controversial at the moment. But those advisory committees convened by federal agencies, CDC, NIH as well, brings together national and international experts to review the literature, to understand what really has been proven to work and what should we promote through guidelines, which again, it's not regulatory, but it's a guideline that people can follow across the country. What are the other cross-agency partnerships? Who did you work with at CDC to make sure patients and healthcare workers were safe?
When I became a division director, I was lucky that Dr. Gerberding was the director of the division right before I was. And she already had started some collaborations with the federal agencies, like the Centers for Medicare and Medicaid Services and a few other agencies. When I was right in the beginning, Bill, of becoming a division director, demands from the public became a big issue. That's when public reporting for the state perspective started. It was the consumer groups pushing for legislation for public reporting of the healthcare-associated infections data by hospitals. And then CMS, because of the Deficit Reduction Act, they should not pay for the infections or the extra amount. So we saw the importance of not just working with CMS in a more, not just let's be friends, but let's work together, but also with the states. So that's when, again, HICPAC play a role because HICPAC had a guidance and what states should be doing. We started offering the National Healthcare Safety Network to all the states that had public reporting. When it got to CMS, we're friends, but not exactly, we got along, but they were not using our tools. So what was needed was a GAO investigation. And I always remember Chesley Richards was my deputy, going to meet with Sarah Dupre and Stephen Shah, who were working for Waxman. And they said to us, look, you have this paper showing 70% of infections can be prevented. Why are you not working with CMS so all the hospitals are doing that? We're like, we would love to, but
that's why
but they're like, every time I go there, they're like my friends. They give me candies, but so they did a government accountability office investigation, and what it showed, it was at the end of President Bush's administration. What showed is the agencies were all working in healthcare associated infections, but not together. And he said, guess what? You have to work together. So it became, they had a hearing and they said, we want an HHS action plan and we want to know what each agency is going to do. So don't think that we're just, let's work together. We had to work together. and so
when Julie was the director at CDC, she also got all of the agencies to have representatives at the HICPAC meeting, which put people all around the table listening. I used to love to go to those meetings. I always sat in the corner, tried to keep my mouth shut. I failed all the time, occasions.
But it was fantastic. So with this GAO and the HHS action plan, that, by the way, we had already developed, Chesley, we all had put together, but it couldn't be just CDC to make it happen. We took that seriously and we really worked together. It became a big, big shift in how we did business. when it was President Obama administration, we had to sit in front of the deputy secretary and show if we are going up or down in the goals and why. It was CMS leadership, it was CDC, FDA, NIH. We had to say what we're going to do to change. Can I say one more thing?
Of course.
We had the HHS action plan, and President Obama was elected, and it was Recovery Act. So Michael Craig, who was working with me for the policy, and I were invited to meet with Nicole Kunkel, who was working for Representative Obi from Wisconsin. And she said, okay, the representative is very impressed with this. How much would cost for us to have a program for all the states to have prevention of healthcare associated infections because we want to protect people? Mm-hmm. We said $50 million. We said, okay, 1 million per state. And so Recovery Act had $50 million for prevention of healthcare associated infections. So it was the first time public health was funded to really work in healthcare associated infections. Mm-hmm. And for CMS, he did one more thing. There was a block grant at CDC from chronic diseases that states could get whatever. For a state to get money from the block grant, they had to have a plan to address healthcare associated infections. Still now, they have a person from the HQP at CMS, and we exchange money and everything.
Denise, you were quite exceptionally skilled at getting collaboration across these agencies, and I've seen you in action. Did it come naturally, or what did you learn during your decades of leadership?
I learned a few things. First, having Julie Gerberding as division director, because for the annual report, she would say, tell me the impact. And we say, we published this and this and this. And she's like, no, how many infections were prevented? And we're like, oh, we cannot show that. Yes, you have to show. So it was a way for me to really embrace, yes, we're here to protect people. We're here to prevent infections. We need to show that. We're not an academic center. We're public health. Second, when it was public reporting, there was a hearing. And they asked me to represent HHS. And I was at the hearing, and it was an oversight committee. Nobody explained to me what an oversight committee was. And he would say to me, Dr. Cardo, how many hospitals have you closed? Dr. Cardo, you're killing people. I'm like, I'm not killing people. And then I realized he was asking about HHS. He was asking about CMS. And I had to say, I work with CMS. When I left, I was like devastated. And somebody said, don't be concerned. It's not your role. And then I thought, no, it is my role. I cannot just show what infections are happening. If I really believe in preventing those infections, I have to work with the ones who will make that sustainable. And that's when we put together the concept of elimination program that includes data for action, prevention initiatives with incentives aligned, and innovation. So I thought we need to really work with the ones who can make it happen. And having the patient perspective, the consumer groups involved helped, because they were so upset at us. They would say, why you guys, we, the healthcare epidemiologists, only want to eliminate the preventable infections when everybody wants to prevent all the infections? That's when we all again sat together and said, let's partner, let's make it happen, let's be the voice. Working with everybody was the only way to make that sustainable and not just our problem. We have been able to really show progress. And then I learned that it's better to be ahead than to follow, because they would call everybody before they would call us, members of Congress. Mm-hmm. So I'm just saying, how was the learning process?
You both have been in the field for a long time. What do you think we do differently now that has prevented infections and saved lives?
In my view, what do we do different? We're not think about just the infection. We think about the patient that has many devices, many risks in treating the patient. And I think we had a huge impact in the dealing with the devices. So we changed and we showed that it's preventable. Then we start seeing that there are other sources, the environment, the microbiome. And so now we're addressing that too. So the way I feel, Bill, but I have a bias on that, is embracing the concept that we need to prevent all the infections and how we use innovation and data for that is helping us not just to be stuck in the device related, but is helping us to really move ahead. We're always going to be surprised, always. Never take anything
Yep.
for granted. I remember in the beginning, while we were talking about bloodstream infection, I would give a talk in which I would show bloodborne pathogens being transmitted because of injection safety, people using the same needles in the United States.
Mm-hmm.
So I always
Between different patients, the same
between
deal.
different patients or a single dose vial to more than one person. So I always say, don't take anything for granted. This is the best success that we have had, not just for healthcare epidemiologists, but for patients and clinicians and society overall.
I think from my perspective, I think it's taking the epidemiological approach that Denise has been talking about for all of these problems. And so looking at sort of the global problem of device-associated bacteremia, let's say, and starting from the very beginning, like, should we be wearing sterile gear when we put these catheters in? How should we clean the skin? Analyzing every single thing that we're doing to try to make certain that we're mitigating risk the best way we can. And I think that's the approach that CDC has taken to all of these different classes of infection. Some of them are easier than others. I think healthcare associated pneumonia, it's still something of a mess. I think it's hard because it's multifactorial. You can't really pin it down the way you would like to, the way I think we did, I think, extremely well with device-associated bacteremia. But it's the processing through every single exposure to look at what are the factors that contributed to those exposures. That sort of approach to these kinds of problems is what CDC has really led us through over the last 3 decades. And it's been unbelievably successful.
Bill, can I go back to the partnership in one thing?
Mm-hmm.
Because when we talk about working with other agencies, working with partners, one thing I learned from working with my colleagues, especially in the Washington office, was there is you know a person, you like a person, you trust a person. It doesn't jump from know to trust. It's a process. And in partnerships, you need to get to a point of trust. You don't need to agree, but you have to trust. So you don't second guess the intention. When people ask me during COVID, how come you work so well with CMS? You guys were able to address nursing homes, you were able to do this. I said, because we develop a trust and we talk and we share things. We don't need to agree, but we need to agree in the how. We need to agree in what we want to accomplish. Mm-hmm. David and I had conversations many times over a wine, but about PPE. David and I, because
That's sorry, Denise.
Yeah, sorry. It's like
personal protective
especially
equipment.
The respiratory protection, because David will deal with very rare diseases in which he needed highest protection, and I had to have something for the whole country. So we would talk, and despite different perspectives, but the trust helped me to see how to address and help David to even help me and others. So I say this because it's not just a meeting, it's not an encounter. So I'm not at CDC anymore, and people continue to work with CMS.
David, I think what Denise brought up about the protective equipment, you were quite challenged by when in reading about your accomplishments at NIH, is that you had to prepare the clinical center for Ebola in 2014. So you received patients who had it and were exposed. And I just wanted to hear a little bit about that experience.
That's a great success story. It was a wonderful success story. And it started out by doing almost exactly what Denise said. Rather than focusing in on just the infectious diseases community, we put everybody in the same room and said, okay, we're going to bring these patients here. We want to make the environment as safe as we can. And this went from the CEO's office all the way down to our housekeepers. This is before we had any patients where it was only just theoretical. We developed procedures, strict procedures. We were fortunate enough to have actually the military who had a facility in Frederick where they studied special pathogens. And they sometimes had occupational exposures, and they had a place where they put those people that was referred to as the slammer. And it was as bad as it sounds. Mm-hmm. And so Dr. Fauci was then the director of NIAID, and he worked with Congress and the military to get funding to build a facility that would make care for people who had those exposures safe for our healthcare workers. So we trained the staff, we developed procedures, and we got everybody on board, and we practiced and practiced and practiced. And then after the first patient came, fortunately, it was a healthcare worker who had an exposure who didn't ultimately get infected. We met at 3:00 every day following the person's admission and went through the list of things that didn't work or didn't work the way we thought they were going to. And we learned from that experience. The team functioned extraordinarily well. We did not have a single occupational exposure among our healthcare workers who provided care, I think ultimately for someplace in the neighborhood of 10 Ebola patients, one of whom is the sickest patient I've ever seen survive. I mean, he was really sick. Everyone was on the same page. So we had housekeepers who knew what to do. We had phlebotomists who knew what to do. We had a Watson who watched everything as someone was coming in and coming out of the room, stopping people. And it was incredibly successful. It was probably the most fun I had in my job at the clinical center was putting that team together and then just watching it go. It was wonderful.
And for me, it was terrible because not what he did. What he did showed that what we are recommending worked. And so we had to do that for the whole country. And we underestimated how hard it would be for people to follow. And we had a transmission. It was one of my worst days. I thought I was going to be fired. I remember going back to work the next day. The staff in the HQP, they were like almost crying. And I said to them, it happened. I don't want to point fingers. It's a problem with the system. How we fix the system. It means people cannot follow. So we changed completely our approach. We ended up getting lots of money to really have groups to go and observe and to do things. And Dr. Frieden called me in his office. And I went with Arjun and I said, okay, it's okay. I said, Arjun, if he fires me, it's okay. And then we sat and he said, what do you think? I said, we underestimate. And I don't want to start blaming. I just want to see what we're going to do. From now on, I take the responsibility, but we need to do something that is different. I was not fired, but it just shows how much what we recommend works in a very controlled environment. And that's the reason more and more I believe we need to have special places. At that time, I didn't think it was needed.
So, Denise, this transmission occurred before you had designated sites as places to
They
receive.
were designated sites, but they're also doing in other places. And that's when I thought, don't take anything for granted. Don't think I always say, don't think you know how diseases are being transmitted. We wrote the book chapters saying how they are transmitted, not the pathogens.
Right.
Pathogens know other ways they can transmit, and we don't. So I learned how to never take for granted, but also never quit. And I used to say, perfection is the enemy of action, because we would say we need everything. In some situations, you have to act with what you have, and then you learn and you move forward. And then, because of Ebola, because of SARS, because of flu, it was clear that healthcare was an amplifier of transmission of emerging threats.
Oh, you bet.
And then everybody started paying attention to that.
Let me make just 2 points about that I think that are relevant. One is it's a really good example of the difference between Denise's job and my job. I was worried about one unit in one hospital, focusing on everything that we could focus on, and Denise's worried about 50 sites around the country where she has no direct control over what people are doing. The other thing is it highlights what we talked about at the start, how different the clinical center at the National Institutes of Health really is from other places. When back in the early 2000s, when SARS showed up, I bet I was the only hospital in the United States who had investigators writing protocols to study those patients, to bring them in, even though we didn't have any in the country hardly. But that's what we do. That's what the clinical center does. And so if there's a problem like that, then we're just in it. And that's really different from a lot of other places.
David was saying the beginning of working at NIH at the clinical center, having the positive thing and the negative thing about having very smart people who knew everything. I had the benefit of working with very smart people, not just at CDC, but all over. When we talk for Bob Weinstein's podcast, I mentioned that. People I could call. People we could say, like there was the meningitis outbreak. How do we do with this? We had no idea. Let's get a group and think together. So there was really a lot of fantastic people that I would call to discuss what to do and discuss pros and cons. But I would say at the end of the day, the friends were good, but I learned that it didn't matter what I did, I would be criticized. I tell my friends that now I love going to meetings because nobody asks me for money. Nobody is upset at me because of a recommendation. Nobody's upset because they didn't get the grant. So now I can go. You can see that David and I, we are not at work. We still talk as if we are. We are. Yeah. And the excitement is still there.
If you had one item, literal or figurative, to put in your health bag or public health bag, what would that be? David, do you want to start?
I did spend time thinking about this because I think it hits at one of the things that I find most distressing in my life currently. And that is, I think the country has lost track of science as a discipline and lost faith in science. And if I could have something that would at least allow a pathway back to having sensible reliance on scientific evidence, that would be the one thing I would put in my hospital bag for sure, because in the absence of that, I don't see how we're going to get better.
Denise?
I would say agree with the science. So I would say passion and science for impact, because I think we forget the impact. So that's what I would say.
Thank you both for that wonderful interview. After speaking with Denise and David, I spoke with Dr. Julie Gerberding, former director of the CDC and David and Denise's colleague, who was one of the pioneers in preventing HIV transmission. Julie had this to say.
It's really hard to go back in time and think about the very beginning of the HIV pandemic as it marched around the world. But for those of us on the front line in healthcare, we were scared. And it was really important that we try to identify ways that we could prevent infection in people after needle sticks. San Francisco General was one of the biggest hotbeds for that concern, given the high density of patients. But also David Henderson at the NIH had a similar frontline view. And we kind of mutually arrived at the same point in time in a recognition that it was going to be important to understand the risk, measure the risk in people who'd had needle stick or other exposures. When AZT became available as the first drug for HIV, we said, you know what, we need to think about post-exposure prophylaxis with this drug. But it was a little harder for the CDC to engage, being a government agency and not being able to put out recommendations without data. So that's where Denise and David Bell at the CDC came into play, because they initiated their own needle stick study, which helped refine the risk estimates based on the severity of exposure, but also ultimately got the best data that we have to this very day to demonstrate that among healthcare workers, post-exposure prophylaxis works. So it's really hard to look back on that and realize how nerve-wracking it was to be operating in these uncharted waters. But at the same time, in retrospect, how fortunate we were that this approach probably did prevent infections and certainly created the proof of concept that post-exposure prophylaxis for community exposures, like people sitting on needles in movie theaters, we're calling our hotline, and then people whose condoms broke post-sex, we're calling our hotline. And pretty soon we began to recognize that we needed to broaden our understanding of prophylaxis to include any kind of HIV exposure where there was a point event. Like the famous quote from Isaac Newton, if I've seen further, it is by standing on the shoulders of giants. This whole process was one step after another, building on the insights and the courage, in my opinion, of a lot of people who stepped forward and said, we have to understand this and we have to try something. So kudos to Denise and David and all of the teams, including my team at San Francisco General, who really helped move this forward at a time when we didn't really have any other options. You know, sometimes when you're in the trenches together, most important friendships are formed. And I would say for Denise, David, and me, we were in that trench together. There was uncertainty. There were some pushback perspectives, but ultimately it forged an incredibly enduring friendship, both from a scientific and professional perspective, but also on a personal basis.
Many thanks to our guests for sharing their words, but more importantly, their acts of service. Please email us your inspiring governmental healthcare or public health stories at info@inspiredtoheal.net. Follow Inspired to Heal through LinkedIn or your favorite podcast platform for future episodes and more information. Thank you for listening.
Inspired to Heal podcasts are for informational purposes only and should not be considered as health or professional advice. We are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast. The views expressed do not necessarily represent those of the host or the guest's current or past employers.